Today we're going to start off with each one of you preparing an access cavity for a root canal procedure. Now I don't want you to do anything different from your normal access technique. Just do what you would do in your everyday practice. So I'll give you a few minutes and then I'll look at what you've got. Hi, welcome to Radiculare retreatment. This tape will deal with blocks, ledges, apical transportations, and perforations. Show me a dentist that doesn't get them, and I'll show you a dentist that's not doing endodontics. How do we get into these situations? How can we get out of them? First, let's look at the breakdown. Failure to respect and appreciate the biological and mechanical objectives of cleaning and shaping increases frustration and predisposes to needless complications such as blocks, ledges, apical transportations, and perforations. These iatrogenic events can be attributable to working short of the radiographic terminus, attempting to negotiate and prepare the apical 1/3 of the root canal first, the instruments, and their methods of use. Generations of dentists have been trained to work short of the radiographic terminus. Every dentist who has worked short has experienced the frustration of an apical blockage. A loss of working length occurs due to the compaction of collagenous tissue apically and/or the accumulation of dentine mud. In the instance of the lost foramen, many clinicians become frustrated and aggressively attack the obstacle, which serves to inadvertently condense and pack debris apically. Working arbitrarily short of the radiographic terminus in an apically blocked canal predisposes to a ledge. A transportation results because there's been failure to pre-enlarge the canal and occurs because carrying larger, progressively stiffer instruments to length begins to relocate the foramen on the external root surface. If persistent file grinding continues in a blocked and ledged canal, a perforation may result. Traditionally, clinicians have been trained to work intentionally short of the canal terminus, which promotes a variety of undesirable cleaning and shaping outcomes. The scenario of events usually starts with an apically blocked canal and lost foramen. This commonly contributes to ledge formation. If persistent apical file grinding continues, the blocked and ledged canal eventuates in a perforation. The cases you've seen represent needless complications to non-existent problems. That's the breakdown, but like the hand, there are two sides. Let's look at the other side, the breakthrough. Fulfilling the mechanical objectives of cleaning and shaping also achieves the biological objectives and promotes predictable success. In a continuously tapering preparation, the canal shape must flow and progressively narrow in an apical direction. Starting at the orifice and moving apically, every cross-sectional diameter of the finished preparation should decrease with the smallest cross-sectional diameter at the apical terminus of the canal. It is important that the original anatomy is maintained. Canal systems move through multiple geometric planes and curve significantly more than the roots that harbor them. The economy of the preparation is always a conscious balance between a canal that is three-dimensionally cleaned, shaped, and obturated, and conserving maximum root structure. It is essential the position of the foramen is maintained. Gently and minutely enlarging the apical foramen without relocating or losing its position represents excellent endodontic preparation skills. To maintain the position of the foramen during treatment, small clearing files are passed to and minutely through the apical terminus to prevent the accumulation of dentine mud and, importantly, to maintain patency. Keeping the foramen as small as practical is a discipline, improves preparation results, and promotes confidence during three-dimensional obturation. Clinicians should recall that the mathematical expression for the area of a circle equals pi r squared, and as such, doubling the file size apically increases the surface area to seal by 4-fold. Certain teeth may require that the apical foramen be finished to a size 40 or 50. The clinician should create shape coronal to the radiographic terminus to provide resistance form to hold gutta percha and eliminate the potential for packing overextensions. Endodontic treatment can be simplified by dividing the entire procedure into a series of smaller steps. With exceptions, the vast majority of teeth range from 19 to 25 millimeters in length. Most clinical crowns are about 10 millimeters, and most roots range from 9 to 15 millimeters in length. If we divide the roots into coronal, middle, and apical 1/3, then each third is between 3 and 5 millimeters in length. Let's look at the preparation sequence. Cleaning and shaping outcomes are significantly improved when the coronal 2/3 of the canal is first explored and negotiated with small flexible hand files. Small hand files are utilized to either create or confirm available space for rotary instruments to follow. This secured region of the canal can be optimally shaped with as few as 2 rotary shaping instruments, such as the ProTaper Shaper 1 and Shaper 2 NiTi files. When the coronal 2/3 of the canal has been fully shaped, then access is available to more predictably and safely scout and negotiate the apical 1/3 of the root canal system. When we have confirmed working length, established patency, and verified a smooth, reproducible glide path, then we can shape the apical 1/3 and smoothly blend this region of the canal into the coronal 2/3 preparation. Now that we have reviewed the ideal preparation sequence, let's learn what to do when things don't go as planned. A problem recognized is a problem half solved. We've seen the problems and hopefully have an idea of how to avoid the chain of events that leads there in the future. But right now we need to know how to overcome these obstacles when they do occur. Let's convert the breakdown into a breakthrough. The technique is straightforward, and I think you'll pick it up very quickly. Clinicians should take 3 well-angulated radiographs prior to initiating treatment in order to better appreciate the 3-dimensionality of any given tooth. From an endodontic standpoint, preoperative film should include mesial, distal, and straight-on angles. These views will better prepare the clinician for root canal treatment. 3 films, in combination, are more valuable than a single film alone and give us important information as to the buccolingual dimensions of a tooth and root concavities. Importantly, when radiographically evaluating an endodontically treated tooth, when obturation materials are visualized to end short of length, clinicians should anticipate the terminal extent of the canal may be blocked. In other instances, if any radiographic image reveals that the terminal extent of an obturation material is not centered within a root, then the clinician should anticipate that the canal may be both blocked and ledged. Hand files are essential for the management of blocks and ledges. I prefer stainless steel 10 and 15 hand files due to their rigidity and ability to be pre-curved. The 20, 25, and 30 hand files are stainless steel, highly flexible, and safe-ended. These flexo files may be pre-curved to safely follow the portion of the canal secured with 10 and 15 hand files. Seen in the back row are the highly flexible NiTi 35 through 60 hand files. Let's look a little closer at the smaller sized ISO instruments to better appreciate their geometries. Understanding an instrument's design can help us negotiate a block or bypass a ledge. ISO-sized instruments are available in different lengths, but in common they have 16 millimeters of cutting flutes. The cross-sectional diameter at the first rake angle of any file is termed D0. 1 millimeter coronal to D0 is termed D1, while 2 millimeters coronal to D0 is called D2, and so forth. The most shank side cutting flute is 16 millimeters coronal to D0, represents the largest diameter and most active aspect of the instrument, and is termed D16. Each instrument receives its numerical designation or file name from its D0 diameter. Since ISO files have a standard taper of 32 hundredths of a millimeter over 16 millimeters of cutting blades, then the taper of any specific instrument is 0.02 millimeters per millimeter. Micro openers have offset handles which enhance performance by providing unobstructed vision when there is limited access or when operating deep below the orifice. Viscous chelators like RC Prep, Glide, or ProLube are essential and facilitate negotiating a tight or blocked canal to its terminus. Viscous chelators lubricate negotiating files and enhance their ability to slip and slide through or by an obstruction. Viscous chelators emulsify vital pulp and discourage the readherence of collagenous tissue. Finally, viscous chelators hold pulpal tissue, dental mud, and debris in suspension, where they can be subsequently liberated from the preparation through irrigation procedures. The ProTaper night-tie rotary files may be easily converted to manual files using the color-coded snap-on handles. Manual ProTaper files provide a breakthrough in ledge management because they have a modified guiding tip, efficient cutting blades, and greater tapers compared to ISO files. ProTaper files may be used in any portion of a canal that has first been secured with 10 and 15 hand files. Here we're placing the purple snap-on handle on the ProTaper Shaper 1 file. Night-tie files may be pre-curved utilizing the bird beak pliers. The working end of the file is securely grasped between the jaws of the pliers, and the handle is pulled through a radius of between 180 and 270 degrees. Because night-tie files have shape memory, efforts to bend these instruments must be exaggerated so that when the instrument is released from the plier, it will have the desired curvature in its apical extent. Going to length first, working short, not using viscous chelators, and screwing larger, less flexible files towards the terminus all contribute to iatrogenic events like a block. When a block canal is encountered, it is wise to pre-enlarge the canal coronal to the block, as pre-enlarged canals hold a greater volume of irrigant and facilitate the placement of a pre-curved 10 file. If an obstruction is encountered, the pre-curved file is utilized in an apically directed picking action while continuously reorientating the unidirectional stop. The goal is to find a stick. An apically engaged file will demonstrate handle flutter. This information confirms the clinician is following versus making a canal. Using a viscous chelator, gently work the instrument to length and establish patency. Once we have negotiated the canal to its terminus and established patency, then generally it is quite straightforward to shape the apical 1/3 and smoothly blend this portion of the preparation into the upper 2/3. Most clinicians associate a block with an apically obstructed canal. However, lateral anatomy is also frequently blocked, especially when using radial-landed instruments. To mitigate blocking the lateral anatomy, after each rotary instrument, irrigate to flush out gross debris. Recapitulate with a small 10 file. A small size 10 file moved in short amplitude vertical strokes breaks up debris and moves it into solution. Now re-irrigate. Re-irrigation liberates residual debris. Now let's look at how the anatomy gets obstructed when we don't use the proper protocol. Clinicians commonly use a series of nickel-titanium rotary instruments to prepare a canal. Each successively larger instrument performs its own unique work. Each instrument cuts dentin, and the dentin can get moved into the lateral anatomy and obstruct the canals. Dentine mud contributes to a lateral block. After pre-enlarging the portion of the canal coronal to the block, top off the tooth with a viscous chelator. A pre-curved 10 file is used as an explorer. Unidirectional stops allow the clinician to intentionally direct the file in different vectors or pathways. Use short vertical amplitude strokes to move chelator progressively deeper into the canal. If you get a stick or feel a tacky area, that's the place to be. Try to slide to length. If you achieve length, don't remove the file. At this level, little short amplitude strokes
progressively carry more chelator deeper into the canal. Patency is established by deliberately and intentionally and repeatedly moving the file in short amplitude strokes until the instrument is completely loose. Now take progressively longer strokes to ensure that you have a smooth, reproducible glide path. Here's a preoperative radiograph of a maxillary left second bicuspid. Notice the canal has been pre-enlarged in its coronal 2/3. Using the techniques we just saw and a little bit of patience, I negotiated the block and discovered the canal divided apically. The postoperative radiograph demonstrates that the canal bifurcated deep and there are 4 apical portals of exit. This preoperative film of a maxillary bicuspid demonstrates a short fill and a large asymmetrical lesion of endodontic origin. After considerable time, I was unable to negotiate the canal. Because there was radiographic pathology and the patient had clinical symptoms, I gave myself permission to perforate, as the treatment alternative would have been surgery. A post-treatment film demonstrates I bisected the true canal apically and hydraulically packed both exits. In all cases, but in particular this case, a recall examination is important. An internal transportation of the canal is termed a ledge and frequently results when clinicians work short of length and screw instruments into canals. Many ledges are successfully bypassed using the techniques described for blocks. Importantly, pre-enlargement of the canal coronal to the ledge is necessary as this procedure paves the way for the subsequent introduction of pre-curved files. Once the tip of the pre-curved file is apical to the ledge, it is moved in and out of the canal utilizing very short push-pull movements with emphasis on staying apical to the defect. When the file slides easily, it is turned clockwise upon withdrawal, because this motion will tend to straighten the apical 1/3 of a stainless steel file and allow it to rasp, reduce, smooth, or potentially eliminate the ledge, which is typically on the outer wall of the canal curvature. When the ledge can be predictably bypassed, then efforts are directed towards establishing patency with a tin file. Gently passing an O2 tapered tin file 1 mm through the foramen increases its diameter to 0.12 of a millimeter and paves the way for the 15 file. Ledges may be classified into 2 types. A type 1 ledge can be safely eliminated with attention towards observing the 4 shaping objectives to maximize remaining dentin. A type 2 ledge should not be eliminated. Continued shaping procedures may potentially weaken or perforate the root. Let's take a look at how to manage both of these types of ledges. Plastic block scenarios allow us to best visualize their management. Here we have a plastic block with an S-curved canal. Notice at about the junction of the middle and the apical 1/3, there's debris, which infers a block, and you can see that there's a minor ledge. At a higher magnification, you can clearly see the ledge. Although we've emphasized the importance of viscous chelators to manage blocks and ledges, in this plastic block scenario, so you can visualize the management of these procedures, we'll use an aqueous solution. As per usual, we use a stainless steel tin file, and it must be pre-curved. Putting a nice rolled radius on its apical extent allows the instrument to move through multiplanar curvature as we advance it deeper into the root. Notice as we come up against the obstruction, the file will not move apical. Little short amplitude vertical strokes begin to engage the end of the file, and you can see it beginning to move just apical to the debris and bypassing the ledge. Little short amplitude strokes move debris into solution, so that when we re-irrigate, we can flush out some of this debris. Again, the pre-curved file is brought into the root. It's orientated so that it moves past the ledge and a little bit deeper into the canal. I want to emphasize the importance of taking short little strokes when the file is apical to the ledge so that we can smooth and refine this region of the canal. Remember to work in a fluid-filled canal. Again, the pre-curved small hand file more predictably now bypasses the ledge works deeper into the canal and continually refines and expands the glide path. We use a pro taper, Shaper 1, to flare and brush cut the coronal portion of the canal and improve access. This generates quite a bit of debris and necessitates continuous irrigation procedures after each rotary instrument. With improved access, the small pre-curved hand file is free now to go to length. It's worked repeatedly in short amplitude strokes until it is loose. Irrigate and recapitulate and re-irrigate. Well, we've worked a 10 and 15 hand file to length until they were loose, but the ledge is still present. Let's look at ledge management. As we saw earlier in the show, we can take a rotary pro taper instrument and convert it to a manual file using the snap-on handle. A bird beak plier can be used to put a nice rolled radius curvature on the terminal extent of the instrument. By reciprocating the handle of the file, we can walk the tip of the instrument and bypass the ledge. Because this instrument has greater tapers as compared to an ISO 02 tapered file, a little bit of rotation on the handle draws the instrument in and begins to buff out the ledge on the outer wall. Irrigate, recapitulate, and re-irrigate to move debris into solution. To progressively manage the ledge, we use a pro taper shaping file 2. Again, the pre-curved instrument bypasses the ledge. Its greater diameter cutting blades refine and smooth and plane the walls and begin to reduce the ledge even further. This instrument is worked until it achieves length. After every greater tapered instrument, irrigate, recapitulate, and re-irrigate. Here we use the finisher number 1. Notice again that it's pre-curved, and the pre-curved instrument readily bypasses the ledge. This instrument has a 7% taper in its apical extent, and because of this taper, it very nicely can refine and smooth and eliminate the ledge in its entirety. Notice how the debris loads up on the instrument during the cutting action, whether we use a reciprocating handle motion or a balance force technique. Irrigate, recapitulate, and re-irrigate to move debris out of the tooth. When the canal has been optimally cleaned, we want to gauge the foramen with a 20 hand file. By tapping on the handle gently, we can determine if the file is snug at length or loose at length. A medium, non-standardized master cone is selected and trimmed so that its apical diameter matches the last file that was snug at length. The cone is fit in a fluid-filled canal. Following Type 1 ledge management, notice how easily and freely the master cone slides to length. Let's look at how to manage a Type 2 ledge. Again, we have the block with the S-curved canal. Notice that there's more debris in this block than there was in the previous case we just managed. Notice the ledge is probably 50% at least larger than in the previous example. Ledge management is always performed in a fluid-filled canal. A pre-enlarged canal allows a pre-curved file to be easily inserted down to the iatrogenic event. Notice in this orientation, the pre-curved file bottoms out on the shelf and is limited in its ability to move apical. With a little bit of orientation, the file readily drops through the debris, and again the short amplitude strokes move a lot of this debris into solution. Irrigate, recapitulate, and re-irrigate. It's important when pre-curved files are placed apical to the ledge to stay at this position and work the instrument deliberately and repeatedly, because this procedure refines and expands the glide path and makes it easier to introduce progressively larger instruments. The next sequential instrument is the 15 file. The instrument is pre-curved as usual, the handle reciprocated to walk the pre-curved instrument past the ledge. The instrument is worked continuously in an apical direction until we achieve length. Rotary instruments are used to pre-flare and further expand a shaping wave in the coronal 2/3 of the canal. This is the Shaper 1. After it's used, notice the debris needs to be flushed out of the tooth, and again we recapitulate with a small file to make sure we still have that glide path. Let's focus on ledge management. The Shaper 1 is converted from a rotary instrument to a manual instrument, and again, its apical extent is pre-curved. The pre-curved instrument can easily move through the pre-enlarged canal, and its terminal extent can be moved past the ledge, and the instrument is rotated, or you can use a reciprocating handle motion until the instrument achieves length. The next sequential instrument would be the ProTaper Shaper number 2. Again, the pre-curved instrument is going to be reciprocated until its working end bypasses the ledge. Each one of these ProTaper instruments has multiple changing tapers over the length of their cutting blades, and these greater tapered instruments then can begin to refine and expand the glide path, and we can do some ledge reduction. Again, after its use, irrigate and recapitulate and re-irrigate. The recapitulation file again is used in little deliberate short amplitude strokes to move debris into solution so that when we re-irrigate, we can liberate that debris. The next sequential instrument is the ProTaper Finisher number 1. Again, the pre-curve instrument can be readily passed through the pre-enlarged canal. A clockwise rotation moves this instrument in, and its 7% taper begins to carve the shape in the apical extent of the canal. The instrument is worked until it achieves length. Following its use, we irrigate and recapitulate and re-irrigate to liberate the debris from the canal. Move the tin file in short amplitude strokes to encourage debris removal. Following the use of the Finisher 1, we gauge with a 20 hand file. Again, we trim a non-standardized medium master cone such that its terminal diameter matches the last file that was snug at length. This master cone can be put in a dappen dish of alcohol to encourage it to hold a curve, and we'll look at this in just a little bit. Following the shaping procedures, notice that the ledge, although reduced, is still present. In Type 2 ledge management, it isn't always wise to try to remove the ledge in its entirety, or we could predispose the root to either a strip perforation or weaken the root and predispose it to a longitudinal fracture. In this extracted mandibular molar, we have injected a radiopaque contrast solution to clearly demonstrate a large Type 2 ledge.
When working deep subcrestally in cases that are ledged, Dentsply MyFair has brought us an instrument called micro-openers. Micro-openers only have about 5 millimeters of cutting flutes, and their double tapers provides enough rigidity that we can begin to pick into the true pathway of the physiologic canal. The instruments can be pre-curved and have unidirectional stops, and once we kick it past the ledge, a little push-pull motion repeatedly makes the opening into the true pathway a little bit larger and is an opening for placing more conventional instruments.
Micro-openers give us unsurpassed vision, as there is no file handle or fingers to obstruct vision.
The biggest challenge in treating cases where ledges are not removed is trying to have the canal smooth and flowing so that we can, in fact, fit the master cone.
Oftentimes, the master cone will go down the canal, bottom out on the ledge, buckle, and not be able to be carried to length. In this occlusal view, we can see the severity of the ledge and how cone fit could be challenging.
In these instances, we trim the master cone so that it corresponds to the last file that was snug apically. The master cone is measured in the typical manner. We will notch the cone not only to know the vertical extent of working length, but also we'll curve the cone, and the notch will be oriented to be directed with the curvature of the gutta-percha point. This way, when we introduce this cone, we can kick it past the ledge. To enhance that, let's put the cone in 70% isopropyl alcohol, and this will significantly enhance the rigidity of the cone. Now, when the cone is introduced, we can look at the notch on the master cone, and that will tell us where the cone is apically, and we can then insert it very carefully, bypassing the ledge, so that we can get it to the radiographic terminus. Recall the X-ray before we started, noticing the significance of the ledge, and it's great to see after deep shaping, cones slide to place and to length.
This maxillary first molar exhibits previous endodontic treatment. Notice the complications. The patient was referred to me because of a broken instrument in the apical 1/3 of the DB root. However, the patient's chief complaint could be localized to the MB root as there was swelling over the MB root apically in the fornix of the vestibule. Endodontic retreatment focused on the MB root. Upon reaccessing the tooth, we immediately found an MB2 orifice. The MB1 had been previously blocked and was ledged at the junction of the middle and the apical 1/3. Both canals were fully negotiated, the ledge was completely eliminated in the MB1 system, and the canals packed. Notice the curvature and recurvature in the MB2 system. In this preoperative radiograph, note the mesial root is ledged and the carrier isn't tracking the canal. Manual ProTaper files can completely eliminate this type 1 ledge, making cone fit and packing predictable. Notice the postoperative anatomy. Here is a maxillary lateral incisor with a large type 2 ledge. In this instance, I would risk perforation if I tried to completely eliminate this defect. The post-treatment film demonstrates that the ledge has not been eliminated, but importantly, treatment extends to the terminus.
When we carry progressively larger, stiffer files into canals and then grind them to length, we run the risk of apical transportation of the foramen. Regretfully, many dentists have been intentionally trained to take files of sizes 40 and 50 to length. These large files over-instrument the foramen. In my opinion, if a well-shaped canal is flooded with irrigant, it is unnecessary to carry instruments greater than a size 20 to the terminus. Needlessly over-preparing the foramen is an albatross, badly outdated, ill-advised, and its advocacy unsubstantiated. Apical transportation is moving the foramen to a new iatrogenic position. As stiffer files are taken to length, the foramen is zipped and the apical zone of the canal begins to exhibit reversed apical architecture. Canals that don't have a continuous taper over length, or at least deep shape in the apical 5 mm, provide no resistance form for controlled hydraulics, and packing in 3 dimensions is fantasy.
There are 3 types of apical transportations, and each one has a specific treatment approach. A type 1 transportation is a minor movement of the foramen. If sufficient residual dentin can be maintained without weakening or perforating the root, then shape may be created above the terminus and the canal can be obturated in the normal manner. A type 2 transportation represents a moderate relocation of the foramen. In these instances, additional preparation procedures to fulfill the mechanical shaping objectives would definitely be unwise. As such, a barrier should be employed to eliminate moisture and, importantly, provide a backstop to pack against. A type 3 transportation is a severe tear of the physiologic terminus. Regretfully, many canals whose foramens have been ripped and moved on the external root surface will require surgical correction. Mineral trioxide aggregate, commercially known as ProRoot MTA, is a material that creates an extraordinary breakthrough for pulp capping, packing certain canals, and managing radicular repairs. MTA can be used in canals which exhibit reversed apical architecture, such as immature roots or an iatrogenic transportation. It is easy to use, non-resorbable, radiopaque, biocompatible, and is apparently not compromised by moisture. MTA is packaged in a powder form and mixed with sterile water to a heavy, cake-like consistency. We want to incorporate as much powder as we can into the liquid so we can achieve the proper consistency. If, in fact, we have too much moisture, we can blot it with a fiberless gauze to wick out moisture. Wicking gives us a viscous mix and facilitates picking up the material with a modified spinal tap needle. Other devices utilized to carry MTA include the dove gun, the messing gun, and the lead carrier methods. My preference is to utilize the regular length 18 or 20 gauge spinal tap needle that has been appropriately shortened and then utilized to carry and precisely place small aliquots of MTA. The P5 piezoelectric ultrasonic unit affords precise working accuracy. At lower power settings, this generator will deliver a gentle vibratory wave through an instrument, which in turn delivers MTA into a root defect. In straighter canals, MTA can be gently vibrated, moved into the defect, and adapted to the canal walls with a titanium Pro Ultra Endo 6, 7, or 8. A cautionary note is that these instruments should be rounded at their working ends so that they're smooth and won't dig into the outer wall of the canal. Direct ultrasonic energy will vibrate and generate a wave-like motion, which facilitates moving and adapting the cement into the apical extent of the canal. In the instance of repairing a defect apical to the canal curvature, we will need to use indirect ultrasonics. To accomplish this, the handle from a stainless steel hand file can be intentionally removed and the shaft of the instrument inserted into the file adapter. The file adapter threads onto the ultrasonic handpiece and its chuck will retain an O2 tapered hand file. The ultrasonically activated pre-curve file can then be placed into the MTA, and gentle vibratory action encourages the MTA to move and conform to the configuration of the canal laterally, as well as control its movement to and gently against the periapical tissues. The West repair instruments can also be used to carry, place, and adapt MTA. These carrying devices provide thin, flexible trowels angled at different orientations. In the instance of canal curvature, MTA may also be gently tamped down around a curvature to the approximate length by using a customized, non-standardized gutta-percha cone as a flexible plugger. Flexible gutta-percha pluggers, in conjunction with ultrasonics, is yet another option and method to position MTA precisely. As mentioned previously, a Type 1 transportation represents a minor movement of the physiologic foramen to a new iatrogenic location. In these instances, the clinician must weigh risk versus benefit when trying to create an apically tapered canal that is narrowest at the terminus. If sufficient residual dentin can be maintained and shape created above the foramen, then these iatrogenic cases can be three-dimensionally cleaned, shaped, and packed.
Let's look at the evolution of a Type 1 transportation. Initially, smallest flexible files can feed through the pathway of curvature to the radiographic terminus. However, larger files are stiffer, and trying to introduce them into this abrupt curvature begins to rip the foramen. You can see in this extraoral view that there's space around the file because we've already relocated the foramen. We fit a master cone into these cases, and oftentimes with minor movements, we can manage these cases by just packing them in a traditional way. Notice the discrepancy between the gutta-percha cone and the ellipticized foramen. After proper cone fit, sealer is mixed, the cone is liberally coated with sealer, and the cone is teased into place.
Utilizing the warm gutta-percha with vertical condensation technique, we can carry a wave of warm rubber and sealer into the apical 1/3. Following the downpack, note the gutta-percha in this region. In this photograph, note the adaptation of the gutta-percha to the foramen and the thin film of sealer. In this preoperative film of a maxillary central incisor, note the previous access, over-instrumentation apically, and a canal that exhibits reversed apical architecture. A postoperative film demonstrates treatment of a Type 1 transportation. Shaped canals provide resistance form to hold gutta-percha. Here's another Type 1 transportation managed with vertical condensation of warm gutta-percha. Even though the MB preparation apically exhibits minimal resistance form, excellent hydraulics could still be generated during the pack. Recall that a Type 2 transportation represents a moderate movement of the physiologic foramen to a new iatrogenic location. As such, the apical 1/3 of the canal exhibits more reversed apical architecture than a type 1 transportation. In treating these cases, a barrier can be selected to control exudates and provide a backstop to pack against during subsequent obturation procedures.
Here we're going to see the development of a type 2 transportation. Notice the mesial root's curvature and the furcal side concavity. Initially, smallest instruments negotiate the canal and follow the pathway of curvature nicely. Failure to pre-enlarge, and in addition carrying too large of files deep, drags the foramen to the outer wall and relocates it on the mesial aspect of the mesial root. This is a type 2 transportation. You can see here the foramen has been ripped and the file now is excessively long, and this is going to be difficult to manage short of using a barrier technique. When we're going to use a barrier to pack against, we still have to do some refinement of the canals. And even though there's reversed apical architecture in the apical 1/3 of the root, we still need to do some shaping procedures in the upper 2/3 to develop a conical shape preparation to pack into. Gates Gliddens are excellent for moving the canals away from furcal danger and smoothing the transition angles from the occlusal table into the orifice.
During use, Gates Gliddens generate a lot of dentinal mud.
Irrigation procedures are critically essential to float all the debris coronally where it can be cycled off the tooth. With the canals cleansed and enlarged at the orifice level, we can aspirate out the solution and we can begin to think ahead of getting the shape.
Once the canal has been fully prepared, coronal to the defect, MTA may then be carried into the field.
The modified spinal tap needle can be introduced into the chamber and specifically into the canal system that we're addressing. A very simple move of the index finger can place the material precisely. Once the material is in there, we can use a flexible gutta-percha plugger and we can begin to shepherd the MTA into the narrowing cross-sectional diameters. We don't really pack MTA like we would pack gutta-percha. We rather just move it gently because we'll position the material precisely with ultrasonics.
If you have too much power when using direct ultrasonic techniques, consider placing a 15 or 20 file into the mud and using indirect ultrasonic techniques on the shank side of the instrument. This will create a gentle wave-like action, and the material will adapt nicely to the intaglio of the canals.
I like to use a wet cotton pellet attached to a barb brooch to clean up the coronal aspects of the systems. This also tends to scrape all the residual material off the walls. The butt end of a paper point can wick the surplus moisture, and now you're getting a good look at the MTA deep.
MTA requires 4 to 6 hours to set brick hard and requires moisture to accomplish this reaction.
We'll have moisture out on the PDL side, but we also need moist cotton pellets on the material on the coronal side. So here we are putting in moist cotton pellets and packing them down gently on top of the MTA.
We dismiss the patient, and theoretically, anytime after 4 to 6 hours, it would be appropriate to have the patient come back.
Ultrasonics delivers the MTA with remarkable control, and you can see this clinically and radiographically. In the proximal view, you can see how the merging systems are packed densely with MTA in their apical 1/3.
Anytime after 4 to 6 hours, the patient can be rescheduled and the cotton pellets are removed.
A barb brooch is useful to remove the cotton pellets deep. We're going to check for the relative hardness of the material, and a sharp explorer can confirm if the material is soft or hard. If the material is hard, we simply proceed with the obturation procedures. If, in fact, the material is found to be soft, then we simply remove it, and we repeat the delivery and placement of MTA as previously discussed.
This case will help us review our Type 2 transportation technique. In this pre-op film of a maxillary right central incisor bridge abutment, note a post, and an empty system that exhibits reversed apical architecture. We use ultrasonics to remove the post, and a subsequent photograph confirms the disassembly. Note the breakdown products. The canal is reshaped, cleaned, and high magnification reveals the foramen. MTA is introduced, this time on the side of a West Perf repair instrument, then tamped into the apical 1/3 with a gutta percha cone used as a flexible plugger. We can use direct or indirect ultrasonics to deliver MTA precisely to place, and in this instance, we see the Endo 5 vibrating the material densely into the apical 1/3. After 4 to 6 hours, we can pack the case if the material is brick hard, and a 6-year recall demonstrates the new bridge, post, and the non-surgical efforts and excellent osseous repair. Another photograph demonstrates the restorative efforts. The predictability of this technique is exciting.
Let's look at the development of a Type 3 transportation. Initially, smallest, most flexible files follow the pathway of curvature to the terminus. However, carrying larger, stiffer files apically move the physiologic terminus and relocate it on the outer wall of the mesial root. These iatrogenic events are not conducive to conventional treatment and regretfully will require surgery to correct.
Here's a case that illustrates a Type 3 transportation. Preoperative films of a maxillary left first bicuspid show a packed buccal canal that does not fulfill the mechanical objectives for shaping canals. Following flap elevation, a surgical photograph shows gutta percha exiting through a significantly ripped, torn, and relocated foramen. A surgical photograph shows the osteotomy, apicoectomies, and the ultrasonic root-in preparation associated with the lingual canal. Another surgical photograph shows the ultrasonic root-in preparation of the buccal canal. Looking through a Sapphire Plus micromirror, we can see the finished buccal root-in preparation. A 4-year recall demonstrates the apically corked canals and excellent osseous repair.
Subcrestal perforations certainly pose a serious threat to an otherwise favorable endodontic outcome. Most iatrogenic perforations are confirmed when evaluating 2 to 3 different well-angulated radiographs or are noted clinically when copious bleeding is encountered. When this happens, the emotional reaction is a sense of anxiety, usually followed by a panic attack. What do we do?
In order to manage perforations, we must first understand them. The 4 dimensions of a perforation are level, location, size, and time. Perforations occur in the coronal, middle, and apical 1/3 of roots. Furcal floor perforations have similar considerations as coronal 1/3 perforations, and for practical purposes can be placed in this category. Perforations at this level pose different treatment challenges as compared to more apically occurring perforations. In general, the more apical the perforation, the more likely the need for surgical correction. Perforations occur circumferentially on the buccal, distal, lingual, and mesial aspects of roots. The location of the perforation is critical if surgical access is considered and significantly less important when performing non-surgical techniques. The size of a perforation will greatly affect the clinician's ability to establish a complete seal. Lateral perforations have additional challenges as they are never round, but rather elliptical in shape by nature of occurrence. The challenge is to technically seal a space whose total size reflects the area of a circle and additionally is ovoid in configuration. Perforations create inflammatory reactions with resultant loss of attachment. Loss of attachment leads to combined endodontic periodontic lesions, which frequently escalate into additional procedures and a lowered prognosis. In general, repair the perforation during the appointment it occurs to discourage loss of attachment and sulcular breakdown, as chronic perforations with attendant bone loss pose greater treatment challenges.
Now that we've seen examples of the 4 dimensions of perforations, let's look at the tools we'll need to manage these defects.
The dental operating microscope is a critically essential part of the armamentarium in non-surgical retreatment. In my experience, Carl Zeiss has a line of superior products. Specifically, the Pro Ergo has magnetic clutches. This feature, in conjunction with rotatable and inclinable oculars, allows us to get into great position for patient care. Doctor stools are important with the armrest feature because it allows us to have shoulder support and lumbar support so we can be comfortable during our procedures. The pistol grip handles allow us to adjust the light intensity, focus, and the zoom feature. A well-angulated radiograph provides a 2-dimensional image of a 3-dimensional object. As such, electronic apex locators can more predictably tell us the exact position of a perforation defect. The Strapgo 3-way adapter inserts into a triplex syringe, and its distal end contains lure lock threads to facilitate attaching specific tips. This device can be set up to be pressure regulated and serves to collimate both water and air when managing perforation defects. Colicoat is biocompatible, resorbable, and may be utilized as a hemostatic agent or barrier material when managing perforations. Specifically, appropriately sized pieces of Colicoat may be packed through the defect into the osseous crypt until a solid barrier is created at the external cable surface of the root. When utilizing the resorbable barrier Colicoat, the restorative material of choice is Super EVA. Super EVA resin cement is a well-documented, biocompatible restorative material utilized for repairing radicular perforations. However, after achieving crypt control, one drawback with Super EVA is that it's a little bit difficult to mix and sets rapidly. Like Colicoat, Capset is another biocompatible, resorbable material that promotes hemostasis. Capset is the barrier of choice when utilizing the principles of wet bonding. Importantly, the perforation defect and the barrier can be rinsed of contaminants and prepared for adhesion dentistry. Tubulicid Red contains EDTA and releases fluoride and is an excellent wet bonding agent to clean the preparation and improve the restoration to dentin seal. A Focu-tip attached to the wand of a curing light serves to collimate light into restrictive areas and facilitates bonding procedures. As discussed earlier in the show, MTA exhibits excellent tissue biocompatibility and when managing perforations can be used both as a non-resorbable barrier and restorative material. As seen in the transportation section, MTA is packaged in a powder form and then mixed with sterile water to a heavy cake-like consistency. A regular length 18 or 20 gauge spinal tap needle can be appropriately shortened and utilized to carry small aliquots of various materials, including MTA. The West Perf Repair instruments provide thin, flexible trowels angled at different orientations. These instruments carry, position, and adapt materials into more coronally positioned perforation defects. Gutta-percha cones, utilized as flexible pluggers, offer yet another option to shepherd or pack materials to place. The gutta-percha cone is customized by trimming its apical extent so that it has sufficient diameter to effectively work. Importantly, this customized cone should fit freely through the perforation defect and not bind onto structure. As seen in the transportation section earlier in this show, MTA can be gently vibrated, moved into a defect, and adapted to the canal walls with parallel-walled ultrasonic instruments such as the Endo 6, 7, or 8. In this application, these instruments' pointed, most distal ends should be rounded off to prevent marring the internal walls. Direct ultrasonic energy will vibrate and generate a wave-like motion, which facilitates moving and adapting a material like MTA to place. We've seen the ultrasonic file adapter earlier in the show. This device can also be utilized when managing perforations. Importantly, perforations occurring apical to canal curvature. Once MTA is delivered to the target zone, a pre-curve file inserted into the file adapter can be utilized to gently vibrate MTA into a root defect. Many perforation defects exhibit massive bleeding upon re-entry. Calcium hydroxide, a time-honored material, can be passively syringed into the canal, hydraulically moved to place, and allowed to remain in the canal defect for 4 to 5 minutes or longer. Calcium hydroxide is then flushed from the field using sodium hypochlorite. 2 or 3 applications of placing and then removing calcium hydroxide usually begins to control bleeding. This mandibular molar was previously perforated during an access attempt.
Looking down into the occlusal opening, we can see the perforation site. Simulated bleeding will help clarify some of our challenges. In this case, we can use a piece of Colocoat to hold the position so the debris doesn't fall down into the bone when we expand our access cavity. Using a tapered diamond, we can flare back those walls, and it's amazing how you can begin to see nuances like fractures in some of these axial line angles. Gate-slidden drills oftentimes can be used right at the orifice entry because that'll face off the orifice and allow us to more easily introduce files during subsequent clean and shaping. However, one doesn't really want to worry about clean and shaping at this time. It's more important to make sure you can find all the canals. Notice that we have a little bite. There's handle flutter. That's the distal buccal. We want to hold these systems, and so we can use a piece of cotton pellet or a Colocoat. Cotton pellets sometimes have nuisance fibers, and they can be irritating to our line of vision, so Colocoat's good. Barb broach can come in and snag out that piece of Colocoat in the perf site, and many times clinically that'll prompt or provoke additional bleeding. Colocoat comes in sheets, and small pieces are appropriately sized and cut, carried over into the field with cotton pliers and placed in the pulp chamber, and a plugger is selected whose cross-sectional diameter at its working end is slightly smaller than the defect. This allows us to pack the pieces through the defect with intentionality, but yet not bind onto structure. Several pieces may be necessary to fill up the osseous crypt based on the chronicity of the defect, but we got to remember to bring the Colocoat up to the boundary line between the PDL and the external cable surface of the root. If we put in too much Colocoat, we would be in tooth structure, and that material would be resorbed away in around 10 to 14 days. The last few pieces that are placed in can be packed with quite a bit of intentionality because we want a nice firm barrier to pack against. The preparation can be dressed out with ultrasonics, giving us unsurpassed vision and control, and then we can acid etch to provide a cleaner tooth surface if we feel this is appropriate. Now, we can choose from a variety of materials at this point, but in this case, we used Super EVA resin cement. The consistency of the mix is critical, and its correct use is important to manage these defects properly. Mix as much powder into the liquid as you can, but such that the material still has a sheen. If there's a sheen of the material, it's very moldable, it's adaptable, and an oversized plugger can be used to condense it to place. It's fine to overpack the material and carry it out past the margins, because once the material begins to set, a spoon can curette it back and give you sharp margins, and the perforation defect can be dressed out and managed.
Here is a central incisor that has been previously perforated. Note the position of the canal has been protected by using a small piece of Colocoat. Recall, when there are aesthetic considerations, we need to choose the correct barrier restorative.
In this instance, we're going to use calcium sulfate, a marvelous material that's absorbed in about 7 to 10 days. We carry it in with a spinal tap needle and inject small controlled aliquots into the defect. West Perf Repair instruments trowel the material into the defect and begin to shut down the bleeding. Flushing the field out clarifies our vision, and it allows us to place more calcium sulfate into the defect. This material is condensed purposefully out into the bone. Progressively add calcium sulfate, not only filling the entire osseous defect, but part of the tooth structure. Ultrasonics is an excellent tool to finish out the cavity preparation. We can use the principles of adhesion dentistry on an anterior tooth to repair perforation defects. We'll acid etch, and we'll use the principles of wet bonding. Additionally, use the bonding agent of your choice and light cure. The bonding agent is a very thin translucent material, and then this is a preparation for your final restoration, which should be a dual cured material.
The restorative is finished, and you can see how we manage this coronal 1/3 perforation. This preoperative film of the central incisors reveals crowns, posts, inadequate endodontics, a mesiocrestal perforation, and osseous pathology. The crowns were removed and ultrasonic techniques eliminated the post. A photograph following disassembly procedures reveals the true canal and a mesiocrestal perforation. Through this defect, you can see the granulation tissue. Essential to perforation management is hemostasis. Notice the bleeding emanating from the defect. A paper point may be utilized to measure the distance from the reference point to the external root surface. And appropriately sized pieces of colocoat can be packed into the osseous defect to arrest bleeding and provide a resorbable barrier. Colocoat is packed through the defect into the osseous crypt until a solid barrier is created at the external caval surface of the root. A small conical-shaped aliquot of super EVA cement is packed into the defect with a plugger, optimally adapted with a ball burnisher and finished with a West Perf repair instrument. A postoperative film shows the management of the perforation, and a 1-year recall film demonstrates the endodontic and restorative treatment effort and the progressive apical and lateral osseous repair. A photograph taken during this recall visit reveals the new crowns, healthy tissue, and the surgical scar from the previous treatment. Here is a case referred due to endodontic complications. Notice the previous access, possible perforation through the furcal floor, and the apical lesions. The bridge needed to be removed because it was defective. A photograph demonstrates complete access, the identified orifices, and a frank furcal floor perforation. Pieces of colocoat are placed over the orifices to protect them, and calcium sulfate is introduced into the perforation with a modified spinal tap needle. A West Perf repair instrument can then trowel the calcium sulfate into the osseous crypt and dentin defect. When the calcium sulfate has set brick hard, then this barrier material can be finished flush to the external caval surface and the perforation cavity ready for repair. In this case, the principles of wet bonding are applied, and a photograph shows the perforation repair utilizing a dual-cured composite resin restorative. Once the defect is repaired, the canals are cleaned, shaped, and a cone-fit film reveals the canals are ready to pack. A post-treatment film demonstrates the calcium sulfate barrier in the bone, the furcal repair, and three-dimensional obturation. A 5-year recall film shows the new bridge and osseous repair furcally and apically. The primary causes of middle 1/3 perforations are the failure to appreciate external root concavities, the instruments and their methods of use, and the proverbial misdirected post.
In many instances, the culprit is the Gates-Glidden drill because of its improper method of use. The opening on the caval surface is very long and elliptical by nature of occurrence. The challenge clinically is to control the bleeding. Oftentimes, when placing files down the canal, they'll inadvertently pass out through the perf defect, creating spontaneous bleeding that again obstructs vision.
The trick is to place small instruments into the apical 1/3 of the root, create a glide path, and shape the canals, recognizing these canals are not perfectly isolated from the lateral fluids. Fortuitously, by shaping the canals now, we're less likely to disturb the subsequent restorative material. And additionally, shaped canals can receive colocoat to hold their positions, so we won't become blocked inadvertently during the placement of the restoration.
You can now begin to look towards repairing the perforation. Blot out the surplus blood and mop it out with a series of paper points. Drying the canal completely is probably not realistic, but fortunately MTA is not jeopardized by a moist field. MTA is placed into the orifice. A flexible gutta-percha point can gently shepherd the material in an apical vector. Swirling the cone in an arc adapts the MTA to the walls nicely. More MTA is progressively added, and again, the gutta-percha point moves it down through the canal so that it can be passed out through the perf defect and establish the repair. We need to begin to start cleaning up the surplus MTA. There'll be too much in the canal. And remember, we're going to have to subsequently go back into this case and clean and shape, so we don't want to have MTA occluding the physiologic canal. Small spoons can be used, or you can use a cotton pellet that can be grasped with a barred broach, and this will not only clean the walls, but the wet cotton pellet will tend to tamp and adapt and precisely close off the perf defect. Remember, MTA likes moisture to set up hard, so we'll place a paper point down in this canal. We'll use an irrigating syringe with water and let water run down the paper point, and then we can close the case.
We can have the patient come back anytime after 4 to 6 hours.
We can remove the pulp chamber cotton pellet. We can remove the paper point from the MB system, and then we can remove the piece of colotape or colocoat that we had apical to the perf defect so that we have access to the canal for cleaning and shaping and cone fit procedures. This will allow us to pack in 3 dimensions.
This patient was involved in a car accident, and their general dentist opened the first molar on an emergency basis. The mesial canals appear over-enlarged and possibly perforated. Clinically, upon re-entry, massive bleeding was noted coming from the mesial systems. A gutta-percha cone is placed down the mesial root and demonstrates the massive defect. The bleeding was progressively controlled with calcium hydroxide. Once the bleeding was arrested, gutta-percha cones can be placed apical to the defect to hold the positions of the canals. Currently, the material of choice for these types of repairs is MTA. It's introduced with a modified spinal tap needle. Controlled aliquots of material are inserted. Ultrasonics vibrates the material densely into place, and on a subsequent visit the gutta-percha is removed, and now master cones are fit following canal preparation in order to pack in 3 dimensions. Notice the compaction and the control of the material. The off-angled film demonstrates the anatomical form of this root canal system.
Apical 1/3 perforations pose formidable treatment challenges. The radiopaque solution roadmaps the perforation. These defects oftentimes require surgery to absolutely correct them, but in some instances we can go back in non-surgically and accomplish the goals. Clinically, upon re-entry, these cases are very vascular, so we'll flush with sodium hypochlorite to free up and liberate a lot of the byproducts from the root canal space.
Small hand files are used to tediously negotiate and secure the full length of the canal. A secured canal can be shaped, and a master cone serves to hold its position in preparation for the introduction of MTA.
The MTA typically, when it's introduced, will be just the right consistency, but when it gets into the moisture, it can become too runny. So we may have to add direct powder of MTA into the canal to get that cake-like consistency, which means we can begin to move the material with more control. The paper points blot up surplus moisture, and direct ultrasonics can be utilized to move the material into the desired position. If in fact direct ultrasonics is too vigorous, we can stick a 15 file into the MTA, and in an indirect method, we can vibrate on the shaft of the file, which will make the material slump and it'll float it very precisely into place. We need to temporize the case, so we trim off the paper point and we can run water down the paper point again so that the MTA has water to drive the reaction to a brick hard set. The radiograph shows the master cone in place and an excellent repair on the lateral aspect of the root in the curvature.
Anytime after 4 to 6 hours, the patient can be rescheduled. The cavit can be removed, the cotton pellet removed, and the paper point as well.
When we grasp the gutta-percha point, pull very gently so you don't break it. Notice its curvature as it comes out. The canal is now ready to clean, shape, and pack.
Here's a case that was referred for surgical correction of an apical 1/3 perforation. However, maxillary first molars frequently have an MB2 system, and upon clinical isolation, we see the MB1 orifice and related groove. Small negotiating instruments are used to discover the true pathway to the radiographic terminus, and serially we move through the 10, the 15, and the 20 files. The handle of the 20 file is sectioned off to give us a better view and unobstructed vision during perf repair management. MTA is introduced lateral to the instrument and can be vibrated with direct ultrasonics. On a subsequent visit, the conveniently sectioned file can be removed. The MB1, MB2, and DB and Paolo systems were cleaned and shaped, and the case packed in 3 dimensions. Note the perf repair and all the portals of exit sealed. It is only fair to mention that not all perforated cases can be managed successfully non-surgically. This case was handled surgically. The problem wasn't obvious on the preoperative radiographs, but with the flap elevated, you can see the gutta percha leaving the root on the lateral aspect. This apical perforation required apicoectomy and retrograde type procedures. Note the management of the isthmus between the MB and ML foramina. The post-op film reveals the surgical corrective efforts.
The best prescription for an iatrogenic problem is prevention. When you have an appreciation for the objectives of cleaning and shaping, then smooth flowing preparations result. Excellence in canal preparation is an opening for packing the root canal system in 3 dimensions. Hopefully this tape has shown you not only how to avoid trouble, but when problems are encountered, how to be prepared and turn the clinical breakdown into a breakthrough. Being prepared reminds me of a story. Several years ago, in preparation for a Caribbean sailing cruise, my wife and I spent a few weekends training on the San Francisco Bay so we'd be prepared for our upcoming high seas sailing adventure. Training was rigorous and we worked on techniques like sailing upwind, off the wind, downwind, and running in weather, including storm sailing and tactics. Like a clinician initiating root canal treatment, we were confident in our preparation. Upon arrival in the Virgin Islands, we were eagerly rigged our boat, left our mooring, and under full sail, watched St. Thomas quickly disappear on the horizon. Early in the morning of the 4th day, we decided to leave the protected waters of the Sir Francis Drake Channel and sail upwind to Mosquito Island. The wind was blowing strong and steady at about 30 knots, and the sea was becoming turbulent with large rolling swells. On the horizon, dark clouds formed, and within minutes, the situation changed. The sky grew darker, and we were now plunging into huge waves, moving ever closer towards the eye of the storm. As the wind increased, we were rail under, and the rigging began to groan. Suddenly, we heard an ear-splitting pop, followed by a massive ripping sound. Our mainsail had blown out, leaving a gaping hole. Thanks to our training sessions, we were prepared and had a plan which allowed us to roller reef and reduce sail surface area. Over the next 45 minutes, we avoided disaster by running with the storm. Ultimately, preparation had allowed us to turn a breakdown into a breakthrough. By late afternoon, the sky cleared, the wind and sea calmed, and we arrived at our destination safe and anchored in a fantastic cove. Like sailing, clinical endodontics presents us with opportunities and challenges. The measure of a great clinician is not what you do when things go well, rather, what you do when confronted with a challenge. I trust this tape will be the training session that will help you prepare and will arrive with a plan to turn the breakdowns into the breakthroughs. Thank you for your time and willingness to learn. I look forward to visiting you in another Ruddle on Retreatment. I wish you smooth endodontic sailing and great future success.